Manual small incision cataract surgery when it came had a large incision of about 8 mm or more, but it was smaller and self-sealing compared to the extracapsular cataract extraction with multiple sutures. Initially, the incision location was only superior, now it can be superior, supranasal, supratemporal or temporal. Initially, the incision shape was straight, now it can be straight, frown shape, chevron shape or Blumenthal type. Initially, the incision size was decided by the anticipated size of the lens nucleus and used to be 8 mm or more. Now incision size and location are decided by the amount of preoperative corneal astigmatism. The size can be from 4 mm to 8 mm. The nucleus is divided by various nucleus dividing manual techniques to reduce the size in accordance with incision size. The nucleus dividing technique is called as nucleotomy. Nucleotomy techniques can be broadly divided according to location. Intratunnel phaco fracture technique is the technique by which the nucleus is broken into the pieces inside the sclerocorneal tunnel and taken out through as small as 4 mm incision. Phaco fracture, phacosection techniques. In these techniques, the lens nucleus is broken or cut into 2 or pieces with the help of snare or bisector or trisector or Sinskey's hook inside the anterior chamber. The different methods of nucleus delivery include Blumenthal technique, fishhook technique, visco expression technique, phaco fracture, phacosection technique, intratunnel phaco fracture technique, snare technique, irrigating vectis technique and phaco sandwich technique. Manual small incision cataract surgery is a savior in cataracts with comorbidities. This was a case of ultrabrunescent nuclear cataract with non-dilated pupil. 6 mm intratunnel phaco fracture manual small incision cataract surgery was performed. This was a case of subluxated hypermature sclerotic cataract. Managed very nicely by 6 mm intratunnel phaco fracture MSICS with capsular tension ring and PMMA-IOL. This was intumescent white cataract. This was managed nicely by 6 mm intratunnel phaco fracture MSICS. If we compare manual small incision cataract surgery with phaco emulsification, the manual small incision cataract surgery is faster, economic and comparable visual outcome in cataracts without comorbidities. While MSICS has better visual outcomes in cataracts with comorbidities than the phaco emulsification. Dr. David Chang MD from United States of America says, "In my own practice, I resort to manual small incision cataract surgery for the densest cataracts when I feel that comorbidities such as a crowded anterior segment, coagulopathy, corneal opacity, or severe miosis may make phaco emulsification the riskier procedure for the endothelium or posterior capsule. It is a wonderful option to have in my surgical armamentarium." I concluded that, for the many mature cataracts in this population, most Western surgeons and I would have a much higher complication rate with phaco emulsification than with manual small incision cataract surgery. If surgical-induced astigmatism is planned such a way that there is simple myopic astigmatism of -0.75 to -1.25 diopter at the vertical axis or compound myopic astigmatism of -0.25 diopter sphere -1.00 diopter cylinder at the vertical axis or compound myopic astigmatism of -0.50 diopter sphere -0.75 diopter cylinder at the vertical axis or mixed astigmatism of +0.50 diopter sphere -1.25 diopter cylinder at the vertical axis gives multifocal vision by a monofocal IOL. We found in our study that the eyes with 0.50 diopter simple myopic astigmatism had N18 and 6/9 or better vision in 61% eyes. and 24 and 6 by 9 or better vision in 92% eyes. The eyes with 0.75 diopter simple myopic astigmatism had N6 and 6 by 6 vision in 25% eyes. N6 and 6 by 9 in 50% eyes and N6 and 6 by 12 in 25% eyes. The eyes with 1 diopter simple myopic astigmatism had N9 and 6 by 9 vision in 61% eyes, N9 and 6/12 or better vision in 77.7% eyes, N9 and 6/18 or better vision in 100% eyes. We found in our study that the planned post-cataract surgery 0.75 diopter residual myopic astigmatism provides excellent distance vision as well as near vision by monofocal intraocular lens. It is a simple, effective, and economical option of an extended near vision in contrast to a costly multifocal intraocular lens. The surgical astigmatism-induced multifocal vision is free from the side effects of the multifocal intraocular lenses like halos, ghost image. Most of the corneas have pre-existed astigmatism of various amplitudes. The pre-existed astigmatism is effectively neutralized simply choosing incision size and citing manual small incision cataract surgery. On the contrary, in phacoemulsification, we require costly toric intraocular lenses. It is scientific. It is safe. It is economical. It is a technique-based surgery. It is not expensive technology dependent. It does not need expensive machines and consumables. It can be done safely in all types of cataracts. It can be done safely in all types of pupils. The visual outcome is comparable to any other modality of the cataract surgery.